Hello, everyone, and welcome to today's webinar, Understanding Bundles of Care, Payment Models from Multiple Perspectives. Before we get started, we'd like to go over a few items so you know how to participate in today's event. As you can see, we've taken a screenshot of an example of the attendee interface for the webinar. You should see something that looks like this on your computer desktop right now in the upper right corner. When you join today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection because one might not be working well for you, then you can do so by accessing your audio pane in the control panel. There's going to be a question and answer session at the end of today's webinar, and you will have the option to submit text questions by typing your questions into the questions pane of the control panel. You may send in your questions at any time, and we will have a look at them and address them at the end, so you can send them anytime. Or if you prefer to ask your question verbally, you may raise your hand by clicking on the little hand raising icon when we get to that portion of the program, and we will do our best to call upon you and to unmute you. I'd like to take a moment. Well, first off, let me introduce myself. My name is Jeff Rubin, and I am from Duke University, professor of radiology there, and also a board member of the Radiology Leadership Institute of the American College of Radiology. I also want to express really deep appreciation for our co-moderator, Dr. Kathleen Blake, of the American Medical Association. The AMA has been an invaluable partner in putting together tonight's program from the perspective of collaboration and contributing. I think that you are really in for a treat. We have an incredible selection of presenters that we will be introducing in just a moment. So, here is me. I've introduced myself. Dr. Blake, would you like to say a few words? I think your microphone may be muted.
I am off mute. There we go. First of all, we're delighted to co-host this webinar. I am looking forward to hearing from all of our speakers. This is what I call really at the cutting edge of care. And although our focus tonight will be on radiology and orthopedic surgery, we're also going to try and make this relevant to other specialties that will be thinking about getting more involved in episodes of care or bundles of care. And so let's go ahead with the introductions. Jeff, I think you're going to kick those off.
Yes. So I'd like to introduce you all to our panel of presenters. We have Dr. Kevin Bozek, who is the chair of surgery and perioperative care at Dell Medical School at the University of Austin, Texas. He is a nationally recognized leader in orthopedic surgery and value-based healthcare payment and delivery models. Prior to joining the Dell Medical School, where he is the inaugural chair of surgery, he was the William R. Murray Endowed Professor and Vice Chair of Orthopedic Surgery at the University of California, San Francisco School of Medicine. Dr. Bozek has extensive research and policy experience in the field of value-based healthcare, focused on implementation and evaluation of value-based payment and delivery models. His research has been funded by the Agency for Healthcare Research and Quality, the National Institutes of Health, and the Robert Wood Johnson Foundation. We will also be hearing from Richard Duzak, who is Professor and Vice Chair for Health Policy and Practice in the Department of Radiology and Imaging Sciences at Emory University. Dr. Duzak is currently the Council Speaker and a member of the Executive Committee of the Board of Chancellors of the American College of Radiology. Dr. Duzak is an outspoken supporter of evidence-based policy, longtime leader in physician payment and policy development, a former 3-term member of the executive committee of the CPT editorial panel. Prior to joining the faculty at Emory, Dr. Bozek served as the founding chief executive officer of the Harvey Neiman Health Policy Institute of the ACR, and he continues to work closely with that institute. He previously spent nearly 2 decades in private practice, where he served as president of a large radiology group in his home state of Pennsylvania. Patrick Hammond is the chief executive officer of Emory Healthcare Network. He has leadership responsibility for Emory's clinically integrated network. As Chief Market Services Officer, he is responsible for managed care, market development, and outreach strategies, credentialing, enrollment, and medical staff support, data analytics, and market research. Mr. Hammond is a graduate of Emory University, where he received a Bachelor of Arts degree, and in 1991, he received a Master of Health Administration from Duke University. Let me advance this slide. There, oh, go back a moment, sorry. Christina Ritter, Dr. Christina Smith Ritter joined the Centers for Medicare and Medicaid Innovation in April of 2016 as the director of the Patient Care Models Group. As the director of the PCMG, Chris manages episode and bundle model development and implementation. PCMG's model portfolio includes the Bundled Payments for Care Initiative, Comprehensive Care for Joint Replacement, Oncology Care Model, Home Health Value-Based Purchasing, Medicare Choices Model, and the proposed Radiation Oncology Model. Chris has worked in many capacities at CMS in her career. And before I hand the podium to Dr. Blake to introduce the final panelists that we have here, I just want to offer a little perspective at this point. Hopefully, folks are getting a flavor for the fact that we have a tremendous diversity of expertise here. And from the perspective of a conversation on bundles of care and having a aligned approach to developing bundles that are robust and that meet the needs of providers and payers, it is this constitution of a panel that really is most relevant. And I want to encourage you to listen openly to the perspectives of everybody on the panel to understand from a 360-degree perspective the kind of considerations that really need to come to bear as we consider these value-based payment models. So with that, let me hand it to Dr. Blake. Unmute again.
My husband wishes that I might be on mute more of the time. So it is my distinct pleasure to introduce Dr. Michael Sook, who is a physician, but also, as you can see from the slide, has many other qualifications. But his main qualification for joining us here tonight is his experience as the system-wide chair of the Geisinger Musculoskeletal Institute for the Geisinger Health System, where he is also a professor of orthopedic surgery at the Commonwealth Medical College. In that role, he is managing a very innovative approach to orthopedic surgical care, and that includes level 1 and level 3 trauma centers. And he's been the clinical driving force behind what is known as the Geisinger Proven Care Acute Orthopedic Programs in total hip, total knee, hip fracture, and lumbar spine. So much so that in 2018, he actually disrupted the dialogue on value-based care by developing and then offering the world's first lifetime warranty agreement for total hip replacement. And that has now been extended to primary and revision of total knee replacements. So Michael is also, we're proud to say, a leader in organized medicine and has twice been elected to the AMA Board of Trustees, where he currently serves. And he is also named to the board of the Joint Commission. His role, kicking us off, is to set the stage for this discussion. He'll give you a brief history of bundles. So welcome to Dr. Sook, and I'll turn it over to you.
Kathleen, Jeff, thank you so much for the kind invitation, and Kathleen, thank you for that introduction. As we prepared for this particular session, the panelists and I all thought that it would be helpful to provide a brief history of bundle payments to make sure that people understood that this wasn't a creation of the last year or two, but instead has actually been in our presence in delivering healthcare for the last several decades, and that may come to many as a surprise. In addition, I wanted to make sure that we also had a level set understanding of the fact that there are some very common elements in what we call a bundled approach to value-based care, and how value-based care ultimately fits in within a spectrum, how bundles fit within a spectrum of what we call value-based care. Next slide. And the next one. So as I mentioned, the value-based care models actually comprise a spectrum of different types of payment forms. And in the middle is really the bundled payment type of episodic management. And in that spectrum extend from things like fee-for-service, which is our traditional payment form of medical care, in which a service is delivered and we pay for each individual widget within that care process, all the way to a capitated process whereby all of the things are covered for a single price within a specific given episode or total care. Bundled payments occupy a hybrid role and therefore are in the middle of this shared staircase when it comes to shared financial risk and the degree of integrated provider integration and accountability that could be envisioned. Next slide. So commonplace to bundled payment models are a number of key design elements that are important to keep in mind. And so it's irrespective or agnostic of any particular clinical service. A bundle could be made in any clinical service, but it really has some key elements. So the covered services are one element that are important, and that could be things like surgical care, which would include the pre-surgical visit, the surgery, the inpatient stay, or follow-up care. Other examples would be things like cancer care or chronic care like diabetes. Payment methodologies are another key design element, and that it can be either prospective or retrospective, meaning looking at historical. Retrospective would refer to looking at a historical price that you would pay for a clinical episode, and then seeking to provide care for less than that amount in the next iteration of that delivery. There's oftentimes a accountable entity, and typically it's provider-led or could be a hospital or an independent practice. The episode of care is a key design element, and that's usually defined by some length of time. In most cases, it's either a 90-day bundle or it could be up to a year. Another key component in all bundles are things that involve risk sharing. Meaning that everybody has skin in the game when it comes to the idea of providing care for either lower cost or higher quality. And then the distribution of payments among participating providers. And this is what many people call, in some forms, use the term gain share. And that's where if you beat the objective, then you should be able to gain some upside reward for doing so. Or if you fail to meet that, you should pay some penalty. And then finally, one of the key components to this, in order to keep the full value-based spectrum in mind, is that we oftentimes create these bundles with quality in mind, and that is to set certain quality standards up front and try to achieve or at least meet or beat them as the care delivery is performed. And so just to take you through a very brief history of bundle payments in U.S. care delivery, I just take you to the next slide. And remind us that that bundles, or at least forms of bundles, have been with us since about 1983. And I think most of us would recognize that that episodic payment or payment for a group of services within a certain time period have really existed since 1983. And this is when we moved to the inpatient prospective payment system, moving from a traditional fee-for-service model to the diagnosis related groups that we're very familiar with today. And so in many ways, those were really the first forms of bundles way back in 1983. Next slide. In 1991, CMS began to experiment a little further with this by looking at coronary artery bypass graft surgery, in which they started to involve the demonstration project that included all hospital physician services through the initial hospitalization and any readmissions within 90 days. This is really, I think, the first example of the modern bundle, which put a time frame around that payment and held providers accountable for readmissions and adverse events. In this program, 7 hospitals were selected, and they did so for 5 years. And they found that unnecessary services were significantly reduced by creating commonplace algorithms and evidence-based care models to provide the care. And so this expanded and further accelerated the interest in bundled payments. Next slide. After this, a series of other events began to happen. In 2009, New Jersey, 12 hospitals in New Jersey created a 3-year program called the New Jersey Care Consortium. And in this similar type of episodic payment bundled model, they performed a series of certain episodic care under the same risk-sharing types of penalties for either benefit or penalty if they failed to miss certain quality or cost measures. Next slide. And then in 2009, this is where total joints became really at the forefront the same year in what they called the Acute Care Episode Demonstration Project, in which 5 hospitals in Boston were selected to really examine the role of creating targets, a bundled payment model around total joint replacement. And what they found in this particular project was helpful and hopeful in the sense that they found significant cost savings, particularly in the post-acute arena, but mainly at the time in the reductions in the cost of supplies and implants, which started a very different discussion when it came to looking at the elements of the cost of care in total joint surgery. Next slide. And then in 2013 is really the modern version of what we know in bundle payments. And of course, we're all familiar with the Bundle Payment for Care Improvement Initiative, BPCI, where really the Centers for Medicaid, Medicare Services, CMMI, officially launched their program on which 48 different clinical episodes would fall into the same or similar types of risk sharing and beneficial arrangements. Next slide. And then in 2015, outside of total joints and chronic care, oncology became included in the 2015 oncology care model to demonstrate or establish 6-month episodes for cancer treatment, demonstrating again that the bundles can go beyond acute care episodes, but also involved areas like cancer care really for the first time. Next slide. In 2017, the BPCI model for total joints became further extended into something called the Comprehensive Joint Replacement Initiative, or the CJRI. And CJR hospitals were selected out of certain metropolitan service areas at which all providers were placed at risk, and really put the joint model for bundled care sharing of risk at a much higher level and a higher degree of scrutiny, with also potential for higher reward if beating the initial payment price. Next slide. And that brings us ultimately to where we are today in the value-based care spectrum, to BPCI Advanced, which is just recently launched. And this further extended, I think, the acute and chronic care bundled opportunities. And I think will be the subject for many of the questions that we have at tonight's webinar. So just again, a brief overview of both the history and the common elements. And I hope that this will be helpful as we go on into the discussion phase of this webinar. Thank you very much.
So thank you, Dr. Sook. And I'm next pleased to have Dr. Christina Ritter talk with us from the Innovation Center at the Department of Health and Human Services. I think we've already had the stage set for seeing the role that the federal government has played in initiating these various demonstration projects and then being able to spread them more widely across the country. So Dr. Ritter.
Sure. Thank you so much for having me. It's always a treat to spend some time talking about bundles. Unlike many people here, although perhaps some of the panelists, we do bundles all day, every day at the Innovation Center. And I was going to add one more before I jump in to the question of what we are looking for from physicians and provider organizations. To add to Dr. Sook's long history there, we have an NPRM out right now for the proposed radiation oncology model. And this radiation oncology model is a prospective, to use some of that terminology that was just introduced, payment approach. So there's no, it has risk adjustment and other components, but it's a single payment kind of going forward for a treatment period of time for radiation oncology. And there are two separate prospective payments, one for the physician and one for the facility. So it kind of starts that walk that Dr. Sook talked about, that is walking us from kind of sitting on top of the fee-for-service chassis that bundles do right now, into that sort of next step forward into the prospective space. So I'll just add that to the next foot in forward as we look at the evolution of bundles. So the question for me really is, what do we look for when we start putting together maybe bundles, and what do we look for participation in physicians and providers? So I wanted to say, I'll walk into like, what are the attributes of successful participants? We know some of that from our model evolution, but before I'll even get there, I will say that even though I thought Dr. Sook's review of the different elements were very, very good, we at the Innovation Center continue to think through ways that we can put them together a little bit differently. So each of the models that he introduced and we talk about, they have different approaches to handling the payment. In the oncology care model, for example, there's an upfront payment that comes the minute a oncologist begins a patient on chemotherapy. At the time that we see the chemotherapy start, we start a payment, sort of a per beneficiary per month payment for that individual that is combined with some of the other bundle approaches. So we are always looking to think through ways that we can kind of take those different elements that exist and kind of reinvent them to be appropriate to the different types of clinical settings. And so we continue to look into that space. I would say another thing we've been spending a lot of time looking at is what can we do in, not just in our BPCI where we have a single episode that's going underway, but what can we do to do longer episodes where we sort of incorporate that decision for surgery? And I know Dr. Bozek's going to spend some time talking about that. So at the federal level, we're often spending time trying to think through how to improve on those pieces that we talked about, and also how to make them clinically appropriate given the different types of episodes that would be undertaken. I will say overall bundles is kind of the ideal space for the specialty care, and that tends to be its focus because most specialists are not undertaking care for a very long period of time for a particular patient. That's not always true, but it is frequently true. And so that overarching sort of population risk that we tend to associate with ACOs or managed care organizations really isn't appropriate. And so bundles in its current form, the cross payment system bundles, where we link up the individual bundled payments that exist in the traditional fee-for-service space, you know, that purpose there is to provide a way to introduce value for our specialists. And so that's why the focus here is in the specialty space. So to jump in a little bit into actually, before I do that, I wanted to make one other comment on value payment. The purpose of bundles is really to try and it leads into what we look for in participants, is to try and reframe how we think about care. There are ways, and especially low value care, right? And that's a term that now has become cachet, and people have been spending a lot of time out talking about it. Well, before the current pandemic, we were spending a lot of time talking about it. And there are many different ways to get to low value care, and many of them are the ones that I think folks don't always find so appealing, like prior authorization or utilization management. These are all ways to which low value care can be looked at. But a better way, or it feels to us a better way, is to try and sort of reframe how we think about care delivery so that it becomes organic, and so that those payment incentives are better aligned, both for the practice or the provider and for the outcomes of the patient. And hopefully, in the ideal world, you take away a lot of those extra boxes that exist in the UM or in the prior authorization space, and instead, the drive by aligning the payment incentives in a value space would allow you to not have to deal with that, and instead everyone sort of be focused in the right direction. So one thing we're always looking for is ways to sort of transform the care that gets us out of this like watching, shoulda, rather than allowing people to really deliver the care they want to deliver it. And so what we look for when we're putting together new models, and I would say generally from our research where people are successful, and none of this will sound terribly unfamiliar, is organizations, both providers, hospitals, health systems, and even practices. And I will say we have some participants in our oncology care model, for example, that are single oncologists or one or two oncologists. So we run the gamut of big to small. Is a couple things. One, leadership at the organization has to be committed. If leadership at the organization isn't committed, we've all worked in organization, the investments aren't made and the outcomes don't deliver. And these are financial investments, so you really got to go in and make them in order to kind of realize the outcomes. There usually has to be a clinician champion that is driving the information and interest in the value from inside the organization. It is very hard to form fit that on an organization or on a practice if there isn't a leader, usually in surgery, maybe in medicine, who is really carrying that torch internally. Usually we find people are more successful when they go big. Just entering a single episode isn't going to reframe an organization. And so then the time and attention that it needs isn't given to it. We find that there's more opportunity when what we say whole practice transformation comes underway, or in our bundles models, hospitals take on many, many episodes because they are changing how they're delivering the care in many places. It doesn't make a lot of sense to hire a whole lot of practice care managers just for one episode, right? It makes sense to build that infrastructure in, that IT infrastructure in very broadly. We find that our very successful participants have strong network partners, and we're here with a bit of a radiology focus. So strong network partners in their ancillary services, strong network partners in their PAC services, and something that value does is it forces you to reach out and make those arrangements. And so we have found folks that do that to be very successful. Allow time. Time is always the challenge. A lot of times in our revenue cycle world, we tend to want to see those outcomes right away. And what we see as successful is folks need 1 or 2 rounds through that episode experience often before they are able to start performing in a way that allows them to appreciate the shared savings or benefit from the value payment, to really get their systems down and know how to use them. That's just, you know, common sense, but it's true. We find that successful organizations are integrated in many different value programs. A lot of our health systems participate in every value program that comes out. They negotiate new ones with their local insurer. They're in ACOs, they're in, take your pick. They do bundles, they do OCM, they do as much as they can do. And as I indicated before, we really try to have all levels of participants participate in our models. When we can, we are ultimately trying to get to a point where we have really good research results so we can figure out which elements, which forms of the elements that Dr. Sook talked about are actually going to take us forward in a way that can be broadly generalizable to all physicians and organizations. So maybe I'll stop there and turn it over to the next speaker, but I'm really looking forward to the questions.
Thank you so much, Dr. Ritter, for that great overview and such. It's very hard for me not to just make a quick note about the use of the term ancillary when referring to radiology, a sensitive term for us. I think that speaking for many of the radiologists on the line, we're working hard to shed that moniker so that there is, widespread recognition of our full partnership with all care providers in helping to manage our patients. But an absolutely excellent presentation. Thank you. At this point, let me turn the podium over to Dr. Bozek, I believe. No, Dr. Hammond, sorry, or Mr. Hammond. Please talk to us a bit about the tale of two Emorys and how the financial structure influences bundle design and approaches to bundle acceptance.
Thank you, sir, for the opportunity to talk to the group tonight. I'm very honored to get to do this. To give you just a little bit of background, I've been at Emory now for 29 years and have had responsibility for most of our contracting for Emory, both on our hospital side as well as our professional side during many of those years. And I've had the opportunity to work with a lot of great physicians over the years, and we have done quite a few bundle payments, either with the government, directly with National Centers of Excellence with payers, as well as direct employer contracts with big Fortune 500 companies. And later tonight, as we get into the panel discussion, I'm going to spend a little bit of time at the start of the panel discussion answering about 6 different questions that my colleagues here on the panel asked me to talk through about what are the mechanical details of bringing together a bundle. But really I want to just spend briefly a few minutes to give you a little history that as you're potentially working to bring a bundle together, one of the important pieces is what's the underlying financial relationship of those different providers who would be participating in a bundle, because that can affect how you develop the bundle, how you end up dividing up the reimbursement for the bundle. And as we were talking about and putting this plan together, I was sharing sort of a story of, I've been here with Emory for many years, and sort of saw how some underlying financial structure changed how the provider started looking at the bundles. So back in the 90s, when some of the bundles that were previously noted were coming out, while Emory has always been a sort of clinically integrated and financially integrated system, the underlying financial structure of Emory is where each individual hospital, each individual professional group, even each by individual specialties were set up where they were all sort of accountable for a bottom line profit and loss statement. And so doing bundles back in the 90s, it was a little bit more challenging of getting the various parties together. There were a little bit more win-lose type conversations. Some of the process could be a little contentious at times. Just a quick anecdotal story. I was in one particular meeting where the conversations between the different physician groups were becoming a little contentious in trying to work things out. And it got to a point where the lead surgeon asked the lead anesthesiologist in this particular bundle to sort of step out of the room because they weren't making progress. And they stepped out of the room. Until this day, we're not sure exactly what happened. But when they came back in, the anesthesiologist basically had shared, we'll do what was being asked from the surgeon. So those are a little bit more challenging, but it's dynamics of having to work through, of knowing as you're sitting down with your various partners, what each group and the financial integration that exists. Fast forward now 15, 20 years, Emory has changed its underlying financial integration where, for lack of a better word, there's really one bottom financial line, and there's been a separation between physician compensation and even departmental budgets, specialty budgets that are been sort of separated from the reimbursement that comes into the overall organization. And so with that underlying difference, when we do bundles, it makes it a much more collaborative process. It is not as much of a win-lose conversation, and in some cases, the conversations don't even have to occur. We're able to move forward with an organization, do the best we can in structuring it, focus more on the clinical care, because the finance of the revenue coming in has been separated from how physician compensation works, how expense management works, budget management works in the organization. So just another consideration as you are thinking through potential bundles is, what is the financial relationship? There's other situations where depending, you may have a group of employed physicians and then private physicians that are also part of that care, and then how do you work through that? So those will be a few things that we'll talk about a little bit more in detail a little bit later tonight, as I go into a little bit of considerations of how to design and implement a bundle, and sort of what you need to do to effectively do that, and really do it time and time again. So from there, we'll turn it back over to our moderators.
Thank you very much, Mr. Hammond. Terrific perspective, and look forward to hearing more from you very soon. Next, I'd like to hand the podium over to Rich Duzak, who is going to speak to bundled payments in radiology, considerations for practice, and department leaders. Rich.
Thanks, Jeff. Thank you all for allowing me to participate in this evening's presentation. Could you advance my slide, please? The radiologists this evening are going to be hearing from a lot of other specialties about bundle payments in what I think is a much more sophisticated manner than most of us have heard about before or participated in our clinical practices. And in fact, for some of the radiology attendees from the Radiology Leadership Institute this evening, this might be the most that you've ever heard about bundle payments at all. I personally believe that that's partly related to the unique nature of our practices, which, to Jeff's point, I might argue as a radiologist are not ancillary, but perhaps essential to the delivery of modern healthcare. But the reality, I think, is that very few radiology practices participate at all, or at least in a substantive, meaningful, and importantly, knowing way in bundle payment initiatives. But that said, as our payment models along these lines proliferate, I think our radiology practices are going to increasingly have to consider, A, whether we want to participate, and B, as we all collectively move in this direction, how we should best participate. The Harvey L. Neiman Health Policy Institute, which Jeff mentioned, and in full disclosure, from which I continue to receive research support, has done and continues to do a good bit of work in this domain. In my next couple slides, I'll refer you to the Institute's website for a couple of tools that you might be interested in using if you're a radiologist contemplating getting into this space. In the few minutes that I have with you, though, rather than take an approach too far into the weeds, what I'm going to instead propose to you are three questions that I would encourage you to ask yourself as a radiology practice leader if you were asked to participate or consider participating in bundled payment models, say, from your health system. And I think in my mind, these questions will help you in your decision making and help you in your ongoing due diligence. So let's take them all one by one. If you could advance, please. So the first question is, under the bundle payment model that's being proposed in your health system by your payer or by your health system leadership, are you as a radiology practice actually assuming risk? Again, I think most radiologists are not very familiar with bundle payment models because most of us aren't really substantively participating as individual practices. And so I think that even though bundle payments may be in place in a lot of health systems, radiologists are typically, and particularly for their professional services, I think still paid, whether from the payer or through their health system, in some sort of fee-for-service type of parallel payment mechanism. And so I think what that means is the reality is that many of you as radiologists may be rendering services or may in fact have been rendering services under bundle payment models, such as one of those health systems we heard referred to that was mandated to participate in the Comprehensive Joint Replacement Program, and you may not even know it at all. If it turns out that under a proposed bundle payment program that your role as a radiologist is such that you're going to be still paid, at least in the short term, under plain old fee for service, then at least in the short term, you don't need to do nearly as much homework to make any decisions about your participation. You keep chugging along what you're doing, working with your clinical partners. On the other hand, though, if you're assuming risk, meaning that you could stand to either lose or gain money based upon your performance, then you've got a lot of work to do, and compared with most radiology groups, a whole lot of work to do. Next slide, please. The next question that I think radiologists should ask under a proposed bundle payment program is ultimately who controls the bundle, meaning who's controlling the patient in that episode of care. If you're being asked to assume risk, control is going to be everything, and from a radiology perspective, where our imaging services are relatively expensive in a lot of circumstances, utilization management is going to be key. I think in many of our communities, imaging ordering follows the illustration I have here, the Nike imperative, just do it. The radiologists say, sure, what study do you want us to do? The referring physician says, here's what test I want you to do. And there's not a whole lot of control over the utilization of imaging. But from a point of view of a radiologist perspective, that really doesn't lend itself to participation in a bundle. The reality, I think, in our practices is actually that there's very few scenarios where radiologists actually can control the bundle. If you could advance one, please. The one exception to that, and perhaps the most common of these, is screening mammography. If you think about screening mammography, for example, the imaging downstream to a screening mammogram is typically based on the interpretation of the interpreting radiologist. For example, a primary care physician is probably pretty loath to go against the recommendation of a breast imager and saying, no, she really doesn't need a follow-up ultrasound or a diagnostic mammogram. And for that very reason, as there's been increased interest in potentially all specialties proposing some sort of bundle payment model, the American College of Radiology and our Neiman Health Policy Institute has started trying to prepare for a world in which radiologists might assume some risk in bundle payment models, and that's where we've been doing some of our work. So the Neiman Institute's tool, you see a screenshot for it here. It automatically populates at Neiman HPI, NEIMANHPI.org. And by the way, I don't get any royalties for going to the website, and it's open access to the public. But it automatically populates with data that we have from the Medicare fee-for-service population. So large data sets in Medicare, because our data use agreement allows us to pre-populate it that way. You can enter into your own variables, and what that would allow you to do today, for example, is to identify who the outlier physicians are in your practice that may be recommending much more advanced follow-up imaging than the colleagues, or, for example, is your practice as a whole, through your practice patterns or maybe your case mix, an outlier? And I think the reason that that's important to know up front is you need to know where you stand if you're going to be controlling imaging utilization and therefore managing that risk. So unless you know where you stand to start, you really don't know where you're going downstream. For example, if you're already the overall lowest cost screening mammography episode provider, where an episode, at least in our work, has been 364 days after that screening mammogram, then you're probably far more ready to participate in some sort of lower cost bundle than, say, your competitors in that market if your payers are interested in going into that space. In contrast, if you're the highest cost provider in your community, then you've probably got some work to do. But outside of screening mammography, again, if you as a radiologist don't have any control over utilization, either directly because the episode's a purely clinical one, or indirectly, for example, because your health system really isn't interested in using clinical decision support, but you're still being asked to assume risk, then I think you need to be very wary about your participation because you're just not going to have the levers to address that risk. Next slide, please. And then finally, if you're going to be assuming risk, and if you will have some control as a radiologist over that episode, and again, that's probably uncommon, then you can move on to the next questions. And I think those in my mind are how variable is the imaging as part of that episode with regard to A, the frequency, but also the dollar amount. You're hearing more from other speakers, but I think many of the bundles that have gotten a lot of attention to date recently, particularly ones that I know of radiology practices that are saying that they're at least peripherally participating in, have impacted largely inpatient services. And as you think about what these bundles look like, things like, for example, certainly we've got orthopedic surgeons on the panel far more knowledgeable than me, but things in my mind like joint replacements are a lot easier for us as radiologists to deal with. We're asked to participate in that bundle. They're elective, they're procedural rather than diagnostic, so you're not having a whole lot of imaging workup. They're relatively homogeneous care patterns, and from a radiologist perspective, they're pretty low cost, other than for an occasional, say, PE, CTA afterwards, or a CT of the brain for altered mental status. We're typically talking about 1, maybe 2 radiographs for prosthesis assessment. Not all bundles are going to be that straightforward, and so if you're being asked as a radiologist to say what your role might be in some of these, the Neiman Institute's tool may be helpful in that regard. It's called the Inpatient Cost Evaluation Tool. And again, I'm giving a little bit of an ACR spin on this because it is an ACR resource to our members, and this is an ACR program tonight. Stands for the ICE-T app. And like any tool, it's not perfect, but I think can be used in some scenario planning. And so it's populated based upon a large set of many years of Medicare-based data. Again, our data use agreement allowed us to get Medicare. Some of our private data sets won't allow us to share it. By DRGs, importantly for not only Part A payments, as you've heard about, but also what the professional services associated with the DRG would be, which is not part of the DRG itself. And so you can slice and dice by total episode payments, imaging payments, contribution of imaging to that. For comparative purposes, and you can noodle around with this if you want, I've done a screenshot of the app comparing DRG 470, which I think we're going to be hearing a bit about tonight, which is uncomplicated hip and knee replacement on the left, with DRG 020, which is intracranial vascular procedure with post-procedural hemorrhage and major complications or comorbidities on the right. So, really bad brain bleed with a whole lot of work up downstream to that. And what I've illustrated here is the total Part B professional services dollars. Now, there's always going to be some noise in some of these, so you're going to see on the left, the maximum 100% of radiology, 0%. Data sets are inherently messy, but I would encourage you to look at the mean and the quartiles for these. And I think that's where things get interesting from my perspective. For example, for a joint replacement bundle, radiologist professional payments are, only about 1% of the total payments. I mean, there's probably one portable hip radiograph ranging from anywhere from 0.5 to 2.0% of the overall bundle, if you could advance again here. And I think the other related piece to that is the total professional services for something like that are about $2,000, while the technical part of the bundle obviously is more. So the dollars at risk for us as radiologists of 1% of $2,000 isn't a whole lot, even if you completely miscalculate your role in the bundle. That being said, if you look at intracranial vascular procedure with complications on the right here, things are very different. A lot of high-tech imaging, CT, MR of the brain. The fraction of imaging is, 14% of the total professional spend, ranging from 9% to about 20%. And the total amount of the professional services only, we're not talking about the hospital side, it's about $9,000. And so if you're in a professional group and this is being asked to be part of your bundle, you miscalculate on this one, you could really lose your shirt. So I think what this means here is that, predictable episodes without much variation in cost, particularly if the imaging component is small, are pretty low-risk bundles for radiologists if they're looking to get their feet wet. You're not going to make a lot on these, but you're also not going to lose a lot. Complicated episodes are a completely different matter. I think from a clinical perspective, a health system perspective, these are going to be much more difficult for all of us, but these definitely would not be the ones to dive in at the deep end of the pool if you're a radiologist and health system that's moving in. And if you could just advance to my final slide here. And so if you're a radiologist, again, being asked by your health system partners to consider participating in a bundle payment model, again, the questions I'd encourage you to ask is, number one, will I be assuming risk? Because if the answer is no, at least in the short term, then you're pretty much humming along business as usual. But if the answer is yes, then you've got some work to do with your business managers, working with your clinical partners and all those other individuals as well. The second piece is who's going to control, overall clinical care of that episode. If it's you, for example, like screening mammography, you own this. The ball's going to be in your court, and you've got a lot of work to do. That's probably pretty rare, though. On the other hand, if it's somebody other than you, then you need to ask yourself how you're going to manage the risk that you're assuming, because if somebody else is controlling things but you're being asked to assume risk, then you've probably got some trouble. And I think this gets to some of the relationships that Patrick referred to just a few moments ago. And then finally, how variable is going to be the use of imaging within that proposed episode of care, with regard to not only the frequency, but also the dollar amount and the complexity. Because if it's small, then this is probably not a bad starter for you to get into the space. If the dollars, the variability, the utilization is high, then it's a completely different matter, and you really need to be paying attention to everybody else this evening in the remainder of the program. And so with that, I'll thank you again for including me, and turn things back to the moderators.
Excellent. Rich, thanks so much. You covered quite a bit, a really important material, so very much appreciative of that. We're going to hand the podium over then to our final speaker before we start a panel discussion, and that is Dr. Kevin Bozek, who is going to speak to us about alternative payment models in orthopedic surgery, what we've learned so far. Dr. Bozek.
Thanks, Jeff, and thanks to you and Kathy and the rest of the team for including me. I apologize that we weren't able to get my camera working, so you're just going to have to picture in your mind what an orthopedic surgeon looks like. I think most radiologists have a stereotype of what we look like, so I'm sure that won't be hard for you to imagine. It's a privilege to share the panel with some of my colleagues that I've learned a lot about bundle payments from over the last decade. So I'll start right into our experience in orthopedics. If you go to the next slide. So some of you may be familiar with the Healthcare Payment Learning and Action Network. This is a public-private partnership that's focused on facilitating the transition to alternative payment models that reward value. I would encourage any of you that are interested after this to join this group and participate in their many different educational offerings. But they have developed a framework that varies from category 1, which is fee for service, to no link to value, all the way up to category 4, which is population-based payment. I think some of us think that this is actually not a linear journey, but the idea is that we want to be moving from fee for service to some sort of payment model that incentivizes value. Next slide, please. So what you can see here is the goal statement of the LAN is to accelerate the percentage of U.S. healthcare payments that are tied to quality and value within each market. You can see they set fairly aggressive goals within both the commercial as well as the Medicare and Medicaid programs for transitioning beyond level 1 or category 1 to at least category 2 and hopefully category 3 and 4. So I think this will be relevant, increasingly relevant to all of us in the years to come. Next slide, please. So Michael mentioned earlier that, in orthopedic surgery, we have a long and storied history in bundle payments. I'll acknowledge that my first experience with bundle payments was in 2007. I was part of a team that received a grant from the Agency for Healthcare Research and Quality, a 3-year grant for $750,000 to implement a bundle payment. And at the end of 3 years, we enrolled exactly 1 patient after spending $750,000 of HRQ's money. And that was in 2007. And I'd say in the last 13 years since then, we've certainly learned a lot and accelerated. Michael talked about the ACE program, which was an inpatient only bundle. Next slide. Of course, within BPCI, orthopedic surgery was a major player, and at least one bundle was included. Orthopedic bundle was included in 80% of the BPCI Model 2 participants. Next slide. We now have currently the only mandatory bundle payment within Medicare, which is the CGR program. Next slide. Michael mentioned BPCI Advance, and if you click once more, then we now have bundles with not only Medicare, but also with a number of commercial insurers as well as employers. Next slide. So how did we end up at the tip of the spear? Well, obviously we are a common, prevalent, high cost, and relatively homogeneous episode, which is total joint replacement. So it really lends itself, and it's given us the opportunity to be at the forefront of innovation and value-based payment. Next slide, please. So the basic theory here, and this is probably the only slide I'd want you to take away from my portion of the talk, is that form follows function. And so that the general theory here is that if you change the way you pay people, you will change their behavior. So if you pay people in a fee-for-service model, you will get volume-driven fragmented care. And if you transition to paying people in an episode of care or comprehensive payment, you'll get more value-driven coordinated care. The example I like to use is when we first started doing bundle payments when I was at UCSF. At that point, I had already done 3,000 joint replacements in my career. And it was the first time that I actually sat down with all of the people that were involved in the care of my patients, including radiologists, because I never really had an incentive or reason to do that. I was too busy doing joint replacements and they were too busy doing the things that they do. And we never really had the opportunity to sit down and think about did what we were doing make sense from the standpoint of delivering greater value to patients. So I think if you enter into this realm, I think you need to think about the payment model really being a means to an end to drive transformation in care delivery. Next slide. So what did we learn in orthopedics? We learned that if you change the way you pay people, you get people together, all of the people that are involved in the care of this episode, and you get them thinking differently about how to optimize care, improve outcomes, and reduce costs. And what we found was most of the what Chris Ritter referred to earlier as the low value care was really in the post-acute space. We were sending a lot of patients to inpatient post-acute care, skilled nursing facilities, or inpatient rehabs. And we basically realized that that we could send those patients home and achieve the same or better outcomes. We've now moved beyond sending patients home with home health and just sending patients home with their own resources that are supplied by our practices. So a lot of us have moved even beyond home health. And so that's really what we learned. The next slide will show you, this has been studied, 10 years of experience by Zeke Emanuel and his group, showed that we've been able to reduce the overall spend without negatively impacting patient outcomes. And the next slide is from a recent article from Health Affairs, which shows that there's been about a 1.6% reduction in episode spending if you look across the experience with bundled payments in total joint replacement. That was achieved through these bullets, but primarily care redesign in the post-acute setting. And you could say 1.6% is modest, but I like to say anytime you can reduce cost of anything in healthcare, that's a win. Next slide. But what's really missing from this, and Chris alluded to this earlier in her presentation, is when we look at procedure-based bundles, what you get is what you see here in this X-ray. And I think the radiologist would look at this X-ray and you would probably read it as a well-fixed, well-aligned total knee replacement, which is exactly what it is. And this is from a patient. This X-ray was attached to a patient that showed up in my office 18 months after having a knee replacement in a Medicare bundle that was a perfect bundle by Medicare's definition, a one-day length of stay, discharged directly home with no post-acute care, no rehospitalizations or complications within the first 90 days, but yet showed up at my office 18 months later, completely miserable. And if you click on the next slide, you'll see why. And I think the radiologist can interpret that as a relatively normal knee X-ray. So this is a patient who had a perfect knee replacement, and it was the wrong procedure for that patient. So when you have procedure-based bundles, what you get is very efficient procedures, whether or not that's the right treatment in the first place. Next slide. So we can just click through this, but it basically shows that, as we think about episodes, and if you could just click through, you can think about the inpatient episode. Next would be the inpatient and post-acute. Next would be the post-acute. And where we're really thinking about now is the longitudinal management of disease and how bundles fit into the management of chronic disease. And I think that's where radiologists can play an important role. Next slide, please. So we now have developed, in addition to having surgical case rates that are very common, we've now developed a condition-based case rate that looks at the longitudinal management of patients with hip and knee arthritis that not only incentivizes doing the right procedure at the right time, but incentivizes achieving the best outcome for that patient with the resources available. Next slide. And so this, again, it incentivizes us to think not only about how do we redesign the 90-day episode, but if you click ahead, how do we redesign care for the management of, in this case, arthritis, and that definitely involves radiologists, I think, in a big way. Next slide. And so this is, I think, my last slide. It just shows the results that we've been able to achieve. This shows in our market what the typical spend was in 12 months for a patient initially diagnosed with knee arthritis. And we were able to, in 1 year, reduce that spend by an average of almost 30% per patient over about 1,500 patients in our first year. And you can see a big part of that was reduction in spend in imaging, and this is where radiologists can come in handy. A lot of people with knee arthritis get an x-ray at every visit, every 6, 8 weeks, 3 months, 6 months, and we know that the disease doesn't progress that rapidly, and we don't need x-rays that frequently. And similarly, a lot of patients show up in our offices with MRIs with advanced arthritis, which absolutely does nothing to help us in the diagnosis or treatment plan. So I think there is a role for radiology. So I think the next is my last slide, actually. So sorry, one more, but this is this just shows that I think the big difference between people always ask me, how does this differ from capitation? The big difference is that we're accountable for outcomes. So in capitation, the way you make money is withhold care. In fee-for-service, the way you make money is provide more care. In value-based payments, the way you make money is providing optimal outcomes at the lowest cost. So in addition to being on the hook and accountable for the episode costs, we're also accountable for the outcomes. So the last slide is next. So to summarize, I think musculoskeletal disease is a very prevalent and costly condition, and that's why we are at the tip of the spear when it comes to value-based payment. The management of musculoskeletal conditions is characterized by significant variation in the way we treat in the outcomes and the cost. Next. There's a significant opportunity to drive value through care redesign and payment reform, and the next is my last. And I think that value-based payment models, if there's one thing you'll remember from my talk, really drive care redesign efforts by aligning incentives of all the stakeholders around value delivered to patients. And the last click I would say is that you'll learn from all of us that this is a journey. We've been at this, for me personally, for 13 years, some of us longer, some of us less. But take advantage of the partners that you have available to you that have been at this journey for a while. So thanks again for including me, and I look forward to the discussion.
That's excellent. Thank you so much. What a terrific set of presentations. Before we get into the open question and answer period, we're going to have a more focused panel discussion, and I'm going to ask Mr. Hammond and Dr. Sook and Dr. Duzak and Dr. Bozek to all join us in this. And the purpose of this is to take from Dr. Bozek's most recent comments about the importance of working collectively as we strive to build bundles that encompass a broader context for an episode of care or for disease management more wholly. It really involves getting the community of care providers as well as administrators and payers together to come to understanding and agreement on how to design these bundles, how to scope them, and to address some of the questions that the speakers have been posing. So I'd like to turn to Mr. Hammond first and ask you to talk a little bit about when considering a new bundle proposal, be it from a payer or from yourselves, how do you approach bringing people together from a cultural and organizational, operational perspective to begin to have the conversations? What are the nature of those conversations? What is best practice? What's to watch out for?
Okay. Well, I appreciate that. And I would say as you're thinking about one of these bundles, there's probably about 6 questions that you'll need to collectively answer with the various parties who are participating. And just to quickly go through some of those, I'd say the first question is, who is the payer organization that you are going to be working with on this bundle? And what are they trying to accomplish? Because you have to sort of start with the endpoint in mind. And I would tell you it's different, and you've heard it a little bit as the different panel members have talked tonight, between dealing, say, with a government type bundle where some of it's a little bit more dictated and then you're sort of trying to come in compliance with it, versus a potential negotiation with an employer or a payer. And I would say even there's a difference there between dealing with a national payer, like a Centers of Excellence, or an employer. And it was interesting hearing Dr. Bozek speak to this. A lot of times, at least historically, the payer negotiations have been about sort of driving, what is the most, for lack of a better word, cheap price on a bundle, where when you can get into a direct conversation with an employer, you can have additional conversations, similar to what Dr. Bozek just talked about, of a lot of big employers that have been participating in this have found, well, we got a cheap price for this bundle, but we also didn't get the best outcome or the best quality. And then they've had repeats and others. So I think that's very important of who you're dealing with first, sort of for the external component, and trying to be able to engage, and are you in a position to be able to engage? Then the second is, okay, what are you going to include what's included in the bundle? And we'll talk about this a little bit, but is it for a specific acute episode of care? Is it going to include any discharge care or post-acute other services? Does it include all the providers that are participating normally in that bundle of care? Also, how are the more rare consults? Something that comes up unexpectedly, like you need an infectious disease consult on something. Is that part of the bundle? Is it only for certain providers? Is there some concierge services? Do they want travel involved in that? Is they want hotel? Those things, what is included as a starting point? And I think, again, one of the other panel members also talked about another consideration as you look at the bundle is what's the variation in that type of care? If you're dealing with a particular type of episode of care that has a lot of variation and it's unexplained variation, you may want to be very cautious doing one of these bundles. But if it is where it's a pretty straightforward, path of care, but you have a lot of explainable variation, that really provides an opportunity to really, be successful in these. Then once you know that information, then the question becomes, okay, what is the data you need to be able to provide to those who are going to be participating? And that's where you need to be able to pull, hopefully, from your historical systems, several information of what has been your historical reimbursement for this particular services. And it's not only, and it's really for each of the participants in the bundle. And then ideally, when it really works well, is can you also get not only what have you historically been paid, but what has it cost to provide that care? Because then it allows you to really fine tune what you're doing. And then again, if you're in a competitive bidding situation, and I think again, one of the other panel members mentioned this, do you have market information of, as you're bringing this together, is it going to be competitive? Because your internal information may say, well, this is competitive, but then you find, well, you're not very competitive. And so those are information you need to be able to gather to ultimately give to and share with the stakeholders, because without that information, it's hard to have good, transparent conversations. And so you need to be able to have that information. And then when you have the information, you need to have some analytic resources who can provide the information, cut the information in the way that the care providers want to look at it. And I'll just pick on one working with our orthopedic physicians a number of years ago. We had done some really good cost work with them, and we were working on really putting together a very competitive bundle for a direct employer agreement. And we saw some outlier cases that everything else seemed to make sense. Well, working then with the care teams and the physicians, they were able to almost predict which cases they were going to have outliers on in this particular ones. It was driven by people who were coming in with BMI or had certain presenting conditions. It was amazing how well they were able to predict the cases that were going to hit. And that allowed us to structure a bundle that sort of took those and made special exceptions to that. But the key is getting, matching up that financial data with your clinical stakeholders who can then translate the clinical care to what's happening, and making, everyone a part of that with the discussions and so forth. And then you're really then, as you're working through with your stakeholders, is one, to gain consensus on what is the proposal that you want to put in front, especially if it's a competitive bidding situation. If it's dealing with the government, then you're really deciding, can you deliver at the care that they're telling you you're going to have to deliver, and if it's not mandatory. But then once you do that, then it's okay, if you have to split up the bundle because your underlying financial structure requires that, what's a fair way to do that? And you have to talk through, who are your main that are consistently going to be a part of that care package. In the case of like open heart, there's usually, a cardiothoracic surgeon, anesthesiologist. Usually there's some element of imaging. There's some element of pathology in some cases. That's pretty regular. But then how do you handle those infrequent, that's not going to be on every case? And where does that money come from if it's a comprehensive bundle? So you have to work through that. But I think the other thing I would say, once you work through those, there are two other things that sometimes are forgotten about that ultimately determine a lot of success. Or whether you can, is don't forget about the impact on your revenue cycle. Because depending on how the bundle works, you need to be able to identify these patients as they come into your organization. You need to know, okay, are we going to bill these normal fee for service? Or does everyone have to package all these things together and send one bill to a payer? Well, then how are you making sure you're identifying those individuals? And then when payment comes back, is the payer going to pay like normal fee for service during the time and then do a reconciliation at the end? So does that mean you need to hold back money in case you're out? Or are they going to make a lump sum payment? And if they're going to make a lump sum payment, what's the rules of how you divide that up? And then if there's a patient portion, what if there's bad debt? Who takes the responsibility for the bad debt with those? So that's a very important part of connecting the clinical part with your administrative and billing. And then I think the final part, if you're in a competitive bidding situation, is how do you continuously work with your stakeholders and your clinical stakeholders to constantly be innovating? Because if you're in a competitive situation, you may win like with a big employer and become their exclusive provider, but then your competitors are going to be looking to try to take that business. And so it's not just a one-time thing, it's are you constantly innovating to say, how can we deliver this? And again, after being in this for almost 30 years now, I can tell you when bundles first came out back in the early 90s, there was a lot of bidding wars, but there wasn't a lot of fundamental change in the clinical delivery. And ultimately they didn't last because you couldn't. What I like about some of the changes that occurred more recently is that the ability to change the clinical care for more being lasting is working, but it's that constant re-innovation. So just a few thoughts as you're thinking about these things.
Yeah, that was a tremendous articulation of a lot of experience, a lot of strategy, operational management, financial management, and such. I want to be sensitive to assuring that we get to our open Q&A, but I also want to just give a moment to the physicians here to maybe speak briefly to your perspective as stakeholders working with a hospital administrator such as Mr. Hammond. What best practices might you call upon and highlight, or what things to avoid? Dr. Sook?
And Jeff, actually, it's Kathy. And I'm going to pick on Dr. Sook for a moment, because one of the things that he has been able to accomplish that I really want him to talk about is that it is optional at Geisinger whether an orthopedic surgeon participates in the bundle or not. So talk to us about what you might say is the profile and the requirements within Geisinger so that everybody is successful regardless of what model they are in.
Yeah, Kathy, thank you for that. And obviously there's lots to comment on. There's a tremendous amount of material here that we could talk about forever. But specific to your question, so Geisinger, just by way of background, is an integrated delivery system. It's not quite Kaiser in the sense that we still have a very large portion of what we do that is not capitated and not within an HMO type of format. So we have private physicians as well as employed physicians that work within our 13 hospital system. When we created the bundle within our private model using proven care as our strategy, that's what I think, Kathy, you're talking about in terms of allowing some opt-in or opt-out. It starts with the approach of saying we need to eliminate a high degree of unwarranted variation. And that was the evidence-based approach that we first started down the pathway on as we started to deliver or start to articulate what would be included in a bundle, let's say around total joint replacement or lumbar spine. Unwarranted variation is really the key phrase, because there is allowable variation within the delivery of care. There's not a single orthopedic surgeon that does everything exactly the same way. There are certain evidence-based practices that exist that are fairly concrete, and things like, for example, anticoagulation after total joint surgery is a black and white thing. Whether you use a low molecular weight heparin or whether you use an aspirin is an area of warranted variation. Unwarranted variation would be, I don't want to use it at all. And so as we began to bring our providers together to participate in an evidence-based algorithm development around total joint replacement or lumbar spine or hip fractures, we found that certain amounts of variation would exist in creating this. And so some of our providers felt that within the area of warranted variation that they didn't want to participate necessarily in the bundle, and we allowed for that because we knew that at the end of the day, chasing either algorithm around a specific bundle or an area of warranted variation would still be tracked for the ultimate outcomes. And this goes to something that was spoken about earlier. We started our process on the world of capturing outcomes really around 3 questions. And so you can imagine coming to one of my meetings and saying, okay, I want to do a bundle. And I say, okay, well, first question number 1, are you any good? Well, every orthopedic surgeon says I'm fantastic. And then I said, are you getting better? And they said, everyone gets better. I study every day and I do more practice. And then I asked a very important question. I said, how do you know? And that critical question was the one that really centered our focus on outcomes. And so if somebody wanted to go outside the bundle, they're not immune to an outcomes assessment. And so the ultimate result was, while at the beginning we had a number of outliers who didn't want to participate, the outcomes measure brought everybody back together. And so today, I would say that almost all of our providers are really participating within a truly evidence-based algorithm when it comes to these clinical care episodes. I hope that answers your question, but that's how we were able to get really a movement along the pathway to getting people together and achieving a clinical outcome.
No, that's perfect. And if I could ask a question of Kevin Bozek. Kevin, you touched upon it a little bit with respect to the appropriate selection of patients. You gave an extreme example of someone who had a normal knee getting an operation. But I know that you've also done a great deal of work on predictive instruments to be able to tell ahead of time whether somebody will get the kind of relief or the functional mobility that they seek. So could you talk about the role of those starting points in terms of managing the care of these patients?
Yeah, thanks, Kathy. And that's a really important point. And I think that, you know, in every field, you have to identify what are the outcomes of interest. For us in orthopedics, it's pain, functional status, quality of life. And it's always been surprising to me that, you know, even though we do over 1 million hip and knee replacements a year in the United States, in less than 5% of those do we ever measure those things systematically. And so, as Michael said, implementing an outcomes measurement system is critically important. And what we've done in our case is take it to the next level, which is to really identify upfront using patient-derived factors. So whether it's patient demographics, comorbidities, and their own self-reported pain, functional status, quality of life, using predictive analytics and artificial intelligence to be able to predict how likely they are to achieve their goal, which is to improve their function and reduce their pain from surgery. And we found that's a very powerful tool to be able to use in a shared decision-making conversation. And I think once you move beyond procedure-based bundles, you need those types of tools. I just wanted to mention one really quick thing on the last questions that Michael answered, is that to the point about the interaction and collaboration between physicians and administrators, I can't emphasize enough that many of the speakers mentioned it, that if you don't have a physician champion and an administrative champion, this won't work. And I get calls from health systems all the time that says, would you be able to come out and advise us on setting up a bundle with our practice? And the first question I ask is, who's the physician champion? If they say, we haven't figured that out yet, I say, no, thank you, because I know it's not going to be successful. And so you absolutely need to have both of those people identified up front.
Terrific.
That's very helpful. Jeff, please.
Yes, we have a number of questions, and we're going to try to get to as many as we can. And I think the first question I'd like to ask really kind of dovetails off of Dr. Bozek, what you were just discussing. And that is, as you spoke about predictive analytics. And I wonder if you can unpack for us a little bit more about the nature of the input data that needs to be available, particularly when you start expanding beyond some of the more common characteristics of potential candidates for a joint replacement to factor in comorbidities, for example, patient compliance, socioeconomic factors. How detailed do your models get? Do you look at them stochastically in terms of projecting uncertainty? And can you give us some kind of a general sense of how much data do you need to feel comfortable about your analytics? And at what point to say, we just don't know enough to really pursue a model?
Yeah, it's a really good point, and I'll try to be quick because I know we got lots of questions in limited time. The factors that we input into our model are demographic factors, including socioeconomic status, which we know influences outcomes, medical comorbidities, patient-reported outcomes, and radiographic parameters. And I will tell you that it's absolutely a stochastic model, so that you're not getting a point estimate that says you should or shouldn't have surgery. You're getting a likelihood of benefit, and that's part of the discussion that goes into that conversation with the patient. So it's not meant to be a threshold. It's meant to be informing a shared decision-making conversation with a patient, because we can't be that specific. No matter how much big data we have, we can't be that specific. We all have a gestalt sitting across from a patient. This patient will or won't benefit from surgery, and this just gives us another input, a little bit more objective input into that conversation. But it's certainly not it's not a hard and fast rule, and it certainly can't be used to make a decision one way or the other. It's just another data point into that conversation.
Thank you. And to Dr. Duzak, how can radiologists control costs in the setting of advanced accountable care organization, where most services are part of a bundled payment service or based on population health? How can we use the tools potentially from the NPI to identify the areas where we can have the greatest impact, since most of what we do for the Medicare patients are being paid as part of a bundle?
Thanks. Yeah, Jeff, great question. And I think, I look at that in a couple ways there. Number one, I think Patrick raised a really good point about sort of, as you go into these discussions, what can I do? And I think part of it is just getting out of the reading room and having conversations with our clinical partners, having conversations with our administrators about, what is the end game that you're all looking for here? There's a lot of workflow types of things, I know within our own practices that we can do to improve what we consider our efficiency. I would consider, two real value-added areas for us, which is number one, on making the decision to proceed with imaging, whether it's necessary or not. And, practicing in a quaternary care referral place, there's not a whole lot of good guidance that I can provide, one of our hepatobiliary surgical oncologists. I mean, he knows his space, and I really can't be value added. But on the other hand, we get a lot of referrals from primary care physicians outside of our health system, from nurse practitioners and physician assistants. And I personally think that those conversations with those individuals who are being asked to be just jacks of trades, I mean, I don't know how they do it and practice in that many domains. Those conversations up front could probably eliminate a lot of unnecessary imaging. There's got to be an incentive, though, for us, because, every time I talk somebody out of an MRI, I lose money under fee-for-service. The second piece, though, I think is an opportunity that a lot of us don't talk about as much, which is controlling the quality of our product, which is our interpretation. I mean, how many outside studies do I see, Jeff, that, somebody says, pulmonary nodule, recommend follow-up. Well, what the heck's the follow-up? We've got great guidelines here for what these should be there as well. And so I think pushing radiologists to be more structured in our reporting, more consistent across our practices with our reporting, and more guidelines concordant can really help us be a key piece in overall reducing utilization. But again, a lot of people just say, sure, recommend follow-up, because the follow-up comes to them and they get paid for it. So we have to align the incentives.
Great, thanks. One last question before we bring things to a close, and maybe I'll start with Dr. Ritter for this one, and it relates to the emergence of telemedicine, particularly in this most recent pandemic. There has been such an enabling of not only the technology, but the operational characteristics that have allowed it to be pushed out to large numbers of patients. How does CMS, CMMI view the use of telemedicine within the context of some of these bundles? Do you see it as your role in the construction of the bundles to encourage or potentially discourage the use of telemedicine, or do you just leave that to the providers as a potential cost-saving characteristic?
Yeah, so very interesting evolution in telemedicine, telehealth, definitely over the last several months. And I was actually on a bit of a detail to support a lot of the COVID flexibilities most recently, including a lot of the telehealth and hospital without walls initiative. And I would say a couple of things. One, within our models, we always have, almost all of the models have this telehealth option already. There's already an ability in the bundles, in the oncology model, in comprehensive care for joint replacement model, to use telehealth. There's also the post-surgical discharge visits that could be used for telehealth without sort of need for physician supervision. Those are elements that we've always had in our models. However, we have not seen the uptake in telehealth use across our models to date that we had expected to see. And we've often wondered why that might be. There certainly are some local limitations on telehealth. Some of it has to do with where various institutions have been. What's been fascinating, of course, about this pandemic experience has been the need to use telehealth, and all of a sudden everybody is getting a lot more comfortable with telehealth. And so it remains an open question as to how much we'll see uptick in our models once things sort of settle down from the pandemic. And of course, we hopefully sooner rather than later. I would also say generally the agency has obviously brought more broadly, CMS has been looking very closely at those flexibilities to try and ascertain those which probably could stay. Some of it's statutory, so we can't control that, but taking a good look to see what kinds of flexibilities could remain. And I think to the extent folks have input on that, the agency is always very open to know where folks want to be.
Fantastic, fantastic. Well, we've come to the end of our time, and I just want to begin closing this session by expressing a profound appreciation for an absolutely stellar panel, to Dr. Michael Sook, Dr. Richard Bozek, Dr. Christina Ritter, Mr. Patrick Hammond, Dr. Kevin Bozek, and a special thanks to Dr. Kathy Blake, my co-moderator, and for all the support of the American Medical Association in helping to pull together an absolutely phenomenal group of individuals with so much breadth and expertise. I also want to thank our organizers at the Radiology Leadership Institute, in particular Jen Pendo, who's done a lot of work behind the scenes, Emory Pasco, who's the executive director, Jen Nathan, who organizes from the board perspective these webinar sessions. Thank you, our audience, for your questions. Please contact the RLI at acr.org if you wish. Once you leave today's webinar, you'll receive a survey on this webinar, so we would appreciate if you would complete that and provide your feedback. You'll also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. So, on behalf of the RLI, the American Medical Association, and our presenters, thank you for joining us today, and have a great rest of your day.